Welcome to Roadmap to Residency. Hello everyone, I am Aviraz. Welcome to our Club 250 Matchmaker sessions. We are currently in our nephrology modules and we will be running through some questions with you guys to help you on a journey to a 250. So, which of the following is the most likely cause of the glomerulonephritis in this patient? 35-year-old woman presents to the clinic with facial and periorbital swelling, decreased urine output, and dark-colored urine for the past week. She reports a recent upper respiratory tract infection. On examination, she has hypertension, periorbital edema, and mild abdominal discomfort. Urine analysis reveals hematuria, proteinuria, and red blood cell cast. Serum creatinine level is increased, and there are decreased complement levels. A kidney biopsy is performed showing diffuse proliferative glomerulonephritis with a wire loop appearance. Which of the following is the most likely cause of the glomerulonephritis in this patient? IgA nephropathy, PSGN, membranous nephropathy, FSGS, or rapidly progressive glomerulonephritis. So PSGN, the patient's presentation with recent upper respiratory tract infection, hypertension, periorbital edema, hematuria, proteinuria, and decreased complement levels is indicative of PSGN. The wire-loop appearance on kidney biopsy is a characteristic finding associated with this condition. IgA nephropathy may present with hematuria and mesangial proliferation but is not typically associated with recent upper respiratory tract infection. Membranous nephropathy is characterized by the thickening of the glomerular basement membrane. The focal segmental glomerular sclerosis does not typically present with a recent infection or the characteristic wire-loop appearance. RPZN can present with a rapid decline in the renal function. The association with the recent upper respiratory tract infection makes PSGN more likely. So, this is just a simple classification in regard to SLE. So, for example, if there is nephrotic syndrome, the patient has massive proteinuria, injury to podocytes, edema, or hyperlipidemia. If it is nephritic syndrome, the patient has inflammation, okay? Inflammation, there are breaks in the glomerular basement membrane and there is leakage of cells and protein into the renal tubules. Now, proteinuria is more in the nephrotic syndrome, while there may be slight proteinuria in case of nephritic syndrome. Similarly, hematuria is a typical of nephritic syndrome, while there may be a slight hematuria in nephrotic syndrome. So the nephrotic syndrome consists of focal segmental glomerular sclerosis, minimal change disease, membranous nephropathy, amyloidosis, diabetic glomerular nephropathy. The typical nephritic syndrome consists of acute streptococcal glomerulonephritis, rapidly progressive glomerulonephritis, IgA nephropathy or Buerger disease, Alport syndrome, and MPGN. Now here you can see in the middle, there can be a combination of both hematuria and proteinuria. So these are called as the nephritic nephrotic syndrome. And these consist of diffuse proliferative glomerulonephritis and membranoproliferative glomerulonephritis. Now, talking about the nephritic syndrome or the glomerulonephritis. So, symptoms or examination, there may be present of hypertension, edema, or plus minus hematuria. So, the both IgA nephropathy and post-streptococcal glomerulonephritis frequently occur after upper respiratory tract infection, but gross hematuria of IgA nephropathy occurs synpharyngitic at the same time as upper respiratory tract infection. Whereas PSG and glomerulonephritis patients develop dark urine 2 to 3 weeks after the symptom onset. Also, if there is patient has skin infection with strep bacteria, then after 6 weeks also there may be presence of PSCM. The diagnosis is generally by the urine microscopy, which shows the dysmorphic RBCs and RBCs cast, and the renal biopsy is definitive. The four pulmonary renal syndromes are granulomatosis with polyangiitis, eosinophilic granulomatosis with polyangiitis, microscopic polyangiitis, and anti-GBM disease or the Goodpasture syndrome. Now, they all are treated with steroids and cyclophosphamide. Now, to differentiate them, remember, granulomatosis with polyangiitis consists of otitis, sinusitis, saddle nose, pulmonary infiltrates, granulomas on the biopsy. Now, these all can be associated with nephritic or nephritic syndrome. That's why we are mentioning this here. And the treatment of the nephritic syndrome is steroids. But if it also comes associated with other vasculitis syndromes, then we also want to give steroids and cyclophosphamide. That's why we are mentioning about the vasculitis here. So eosinophilic granulomatosis with polyangiitis consists of asthma and eosinophilia. The microscopic polyangiitis consists of no granulomas in the biopsy and is P-ANCA positive. The anti-GBM disease or the Goodpasture syndrome has pulmonary hemorrhage plus anti-basement antibodies. Now, these are the differential diagnoses of glomerulonephritis. We need to check the complement level, C3 or C4. Now, if it is low or low complement levels, then it may be immune complex mediated glomerulonephritis. The differential diagnosis will be SLE, Slovakian bacterial endocarditis, shunt occurring after vascular shunt placement, cryoglobulinemia, post-infectious, or MPGN. If there is normal component level, then it is called as the post-immune glomerulonephritis. Post-immune glomerulonephritis. The differential will be IgA nephropathy, granulomatosis with polyangiitis, eosinophilic granulomatosis with polyangiitis, or microscopic polyarteritis nodosa, and there can be anti-GBM disease where we need to check the anti-GBM antibody. We have one more question here. So which of the following is the most likely cause of nephrotic syndrome in this patient? A 42-year-old man with a history of type 1 diabetes mellitus uh, presents to the nephrology clinic with complaints of swelling in his legs and face for the past month. He reports a decrease in the urine output and mentions the foamy urine. On examination, there is periorbital edema, ascites, and bilateral lower extremity edema. Lab tests revealed hypoalbuminemia, hyperlipidemia, and proteinuria exceeding 3.5 grams per day. Serum creatinine is within the normal range and there is no hematuria. Which of the following is the most likely cause of nephrotic syndrome in this patient? Minimal change disease, membranous nephropathy, FSGS, IgA nephropathy, or PSGN. Membranous nephropathy. The patient's presentation with the history of diabetes, foamy urine, hypoalbuminemia, hyperlipidemia, and significant proteinuria is suggestive of nephrotic syndrome. In individuals with diabetes, nephrotic syndrome is commonly associated with membranous nephropathy. So again, talking about the nephrotic syndrome, it can be primary or secondary due to either an identifiable process or a systemic cause. The most common primary causes are membranous nephropathy and focal segmental glomerular sclerosis. And the most common secondary cause is diabetes mellitus. There can be peripheral edema, hypoalbuminemia, hyperlipidemia, proteinuria, and hypercoagulability. Differential may be primary nephrotic syndrome. The nephrotic syndrome without an identifiable disease, okay, and nephrotic syndrome occurring in the presence of an identifiable systemic disease is called a secondary nephrotic syndrome. The minimal change disease, the secondary causes include lymphoproliferative disease, drugs, particularly NSAIDs, and infection like syphilis, TB, and HIV. Now, these are the primary causes of nephrotic syndrome. Minimal change disease, sudden onset with heavy proteinuria, more common in children, and associated with atopic disease. Treatment is by steroids. Focal segmental glomerular sclerosis is more in the African Americans, and the treatment is by steroids and cyclosporin. Membranous nephropathy, predilection to clotting, renal vein thrombosis can occur. An observation with AC inhibitors and angiotensin receptor blockers and steroids. MPGN can present with either nephritic or nephrotic features associated with hepatitis C virus. This is important, and cryoglobulins. The non-nephrotic observe nephrotic or worsening renal function, we give steroids. MPGN, the case scenario can give you some symptoms or past history of hepatitis C virus serology. Which of the following is the most likely cause of nephrotic syndrome in this child? Okay, this is a child. A 6-year-old boy is brought to the pediatrician by his parents who noticed sudden onset swelling around his eyes and his ankles. The child appears well, but has significant periorbital and ankle edema. There is no history of serious infections or other systemic symptoms. Lab tests reveal hypoalbuminemia, and urine analysis shows significant proteinuria, but there are no red blood cells or gas. A kidney biopsy is performed and findings show effacement of podocytes food processes. Now, which of the following is the most likely cause of nephrotic syndrome in this child? Membranous nephropathy, FSGS, IgA nephropathy, minimal change disease, or Alport syndrome. So the answer is minimal change disease. The presentation of sudden onset periorbital and ankle edema, significant proteinuria, and hypoalbuminemia in a child, along with the findings of effacement of podocyte food processes on kidney biopsy, is highly suggestive of minimal change disease, which is the commonest cause of nephrotic syndrome in children. So talking about the minimal change disease and focal segmental glomerular sclerosis. So minimal change disease is also called the lipoid nephrosis and often is idiopathic, triggered by recent infection, like immunization or immune status. So 4 eyes. Rarely it may be secondary due to the lymphoma. And there is loss of antithrombin, which can cause renal vein thrombosis in this patient. In light microscopy, there is normal glomeruli. Lipid may be seen in PT cells. The immunofluorescence is negative, and electron microscopy only we can see the effacement of podocyte food processes. So minimal change disease, minimal means there are minimal findings that are seen on the microscopy. Focal segmental glomerular sclerosis can be primary or idiopathic or secondary. Example, HIV infection, sickle cell disease, heroin use, obesity, interferon treatment, or congenital malformations. It can progress to CKD, and it is more common in African Americans or Black people. The segmental sclerosis and hyaluronosis may be there, and it is often negative in immunofluorescence, but maybe positive for non-specific focal deposits like IgM, C3, and C1. On electron microscopy, again, there is also effacement of podocyte food processes. So minimal change disease, child, focal segmental glomerular sclerosis commonly occurs in adult. So which of the following is the most likely cause of nephrotic syndrome in this patient? A 28-year-old African-American man presents to the nephrology clinic with complaints of swelling in his legs and face for the past several months. He reports no significant medical history and there is no recent history of infections. On examination, he has periorbital edema, hypertension, and significant bilateral lower extremity edema. Lab tests reveal hypoalbuminemia, hyperlipidemia, and proteinuria exceeding 3.5 grams per day. Serum creatinine is within the normal range and there is no hematuria. Which of the following is the most likely cause of nephrotic syndrome in this patient? Minimal change disease, membranous nephropathy, FSGS, IgA nephropathy, or post-extracellular glomerular nephritis. Now, FSGS with hypertension. Okay, the patient's presentation with hypertension, periorbital edema, significant proteinuria, and hypoalbuminemia is suggestive of nephrotic syndrome. Focal segmental glomerular sclerosis is commonly associated with nephrotic syndrome in adults, particularly in the African American individuals. Thank you for watching. Keep studying.